Welcome to This Week in Neurology. This week we are covering 10 notable papers spanning 3 broad themes: optimizing acute stroke care and preventative risk assessment, advancing diagnostic precision and pathophysiological insights in neuromuscular and epileptic disorders, and enhancing patient-centered management in chronic neurological conditions. Let's dive in. We begin in the field of vascular neurology, where clinical decision-making is increasingly guided by personalized risk modeling. In the journal Stroke, Chen and colleagues address the therapeutic uncertainty surrounding endovascular thrombectomy for distal and medium vessel occlusion strokes. Utilizing an international registry of 1,007 patients across 37 stroke centers, the investigators developed the MAD-MT score, which balances the clinical need for intervention against procedural risk. They found that a higher National Institutes of Health stroke scale score and the absence of intravenous thrombolysis predicted poor outcomes under medical management, whereas older age and the absence of hypertension or atrial fibrillation predicted endovascular failure or complications. Crucially, the MAD-MT score significantly modified the treatment effect. For patients with high scores of 15 or greater, endovascular treatment yielded significantly better 90-day functional outcomes than medical management, with a median modified Rankin scale score of 3 versus 4. Conversely, for patients with low scores below 15, endovascular treatment actually led to worse functional outcomes, with a median modified Rankin scale score of 2 versus 1, suggesting that aggressive intervention in this subgroup may cause harm. This underscores the need for a targeted approach rather than a one-size-fits-all strategy for distal occlusions. Further highlighting the systemic complexities of acute stroke, a pooled analysis published in PLOS Medicine by Chen and colleagues investigated the incidence and prognostic impact of post-stroke acute heart failure in patients with large vessel occlusions undergoing endovascular treatment. Analyzing individual patient data from 4 multicenter prospective studies in China involving over 3,400 patients, the authors found that post-stroke acute heart failure developed in just over 8% of cases, peaking on the first day after stroke onset. This complication was associated with a roughly 3-fold increase in the risk of a very poor functional outcome, defined as a 90-day modified Rankin scale score of 5 or 6. Interestingly, the risk was highly dependent on stroke etiology. Moderate to severe stroke significantly increased the risk of acute heart failure in patients with cardioembolic stroke, but not in those with non-cardioembolic stroke. Mediation analysis revealed that post-stroke acute heart failure accounted for nearly 8% of the adverse effect of stroke severity on functional outcomes in cardioembolic patients, highlighting the critical importance of early cardiac monitoring and risk stratification in the immediate post-stroke period. Transitioning from acute intervention to primary prevention, a review in Stroke by Ahmed and colleagues discusses the clinical implications of the American Heart Association's new PREVENT equations. These sex-specific, race-free equations shift the paradigm from isolated stroke risk estimation to global cardiovascular kidney metabolic risk assessment. By incorporating kidney function and social determinants of health, such as neighborhood deprivation, these equations provide a more calibrated estimation of absolute treatment benefits. For clinicians, utilizing these equations can refine decisions regarding the intensity of blood pressure control, lipid-lowering therapies, and patient communication using long-term 10-year and 30-year risk estimates. Our next theme centers on how advanced diagnostics and neurophysiological techniques are refining our understanding of neurological diseases. In the journal Neurology, Oliveira Santos and colleagues explore the long-debated origin of fasciculations in the early stages of amyotrophic lateral sclerosis. By applying continuous theta burst stimulation to induce motor cortex inhibition in 22 patients with early-stage disease and 11 controls, the researchers measured changes in resting fasciculation potential frequency in the first dorsal interosseous muscle. Following cortical inhibition, motor-evoked potential amplitudes decreased in both groups, but a significant reduction in fasciculation frequency of nearly 40% occurred exclusively in the amyotrophic lateral sclerosis group. This reduction was even more pronounced, exceeding 54%, in patients who had normal electromyography findings in that muscle at enrollment. Because no such reduction occurred in the disease control group, these findings provide strong neurophysiological evidence that fasciculations in early amyotrophic lateral sclerosis are actively driven by descending corticospinal inputs, reflecting a combination of both upper and lower motor neuron hyperexcitability rather than a purely peripheral process. Improving diagnostic sensitivity is also a major focus in epilepsy management. The investigators established a harmonized 3 Tesla magnetic resonance imaging protocol for the Australian Epilepsy Project and evaluated 1,330 adults across 7 sites. The protocol detected epileptogenic lesions in 12% of patients presenting with a first unprovoked seizure, 18% of those with newly diagnosed epilepsy, and 39% of those with drug-resistant focal epilepsy. Most importantly, when compared to prior standard clinical imaging reports in over 600 participants, the harmonized protocol identified new, previously undetected epileptogenic lesions in 9% of patients. This highlights the substantial diagnostic yield of dedicated, expert-read epilepsy protocols over standard imaging. In a broader conceptual piece in the Annals of Neurology, Savleaf and colleagues propose a paradigm shift in how we view the neurological complications of metabolic syndrome. They argue that peripheral neuropathy and cognitive impairment are fundamentally connected manifestations of shared metabolic injury to the nervous system. To reflect this, they propose expanding the traditional stocking glove description of peripheral neuropathy to a stocking glove hat description, emphasizing that cognitive decline should be actively screened and managed alongside peripheral nerve damage in patients with progressive metabolic dysfunction. We turn now to the management of chronic and rare neurological conditions, where patient-centered outcomes and clear recovery timelines are paramount. In neurology, Pressler and colleagues characterize the clinical phenotype of lipoprotein receptor-related protein 4 antibody-positive myasthenia gravis, using data from the German Myasthenia Gravis Registry. Out of over 1,400 patients with complete antibody testing, nearly 5% were positive for these antibodies, split equally between single positive and double positive with acetylcholine receptor antibodies. The study revealed that patients who were single positive for lipoprotein receptor-related protein 4 antibodies experienced a significantly higher disease burden, with substantially worse activities of daily living and quality of life scores, and required higher rates of treatment escalation and rescue therapies compared to other subgroups. Conversely, double positive patients behaved similarly to standard acetylcholine receptor positive patients. This distinction is vital for clinicians to anticipate more aggressive disease courses in single-positive patients. To better capture patient-relevant outcomes in another complex neuroinflammatory condition, Brenner and colleagues developed and validated the patient-reported outcome scale for encephalitis, known as PROS. Utilizing data from over 200 patients with anti-NMDAR, anti-LGI1, or anti-CASPR2 autoimmune encephalitis, they created a robust 40-item scale covering cognition, behavior, emotional and physical well-being, and daily activities. The scale demonstrated excellent test-retest reliability and successfully captured clinical improvement over time, offering a valuable disease-specific tool for both clinical trials and routine practice. Understanding recovery timelines is also crucial for patients undergoing reconstructive surgeries. In the Annals of Neurology, Missine and colleagues established neurophysiological recovery profiles for 44 patients with traumatic cervical spinal cord injury undergoing nerve transfer surgery to restore upper limb function. They found that the average time to detect voluntary motor unit potentials on needle electromyography varied by procedure, ranging from approximately 7 months for supinator to posterior interosseous transfers to over 10 months for brachialis to anterior interosseous transfers. These precise benchmarks are essential for managing patient expectations and structuring postoperative rehabilitation. Finally, in movement disorders, Sarwinska and colleagues present a systematic review of 90 studies evaluating pharmacological and non-pharmacological interventions in Friedreich's ataxia. They found that while omaveloxolone was the most effective pharmacological agent, and rehabilitation and cardiac interventions were the most effective non-pharmacological approaches, there is a historical disconnect in clinical trials. Pharmacological studies frequently demonstrated biological improvements without clear clinical benefits, whereas non-pharmacological therapies yielded more consistent, patient-relevant functional gains. The authors call for more holistic, patient-centered trials that combine these approaches. If you only have time for one paper this week, make it the study In Stroke by Chen and colleagues introducing the MAD-MT score. This pragmatic tool provides clear, actionable thresholds to guide the difficult decision of whether to perform mechanical thrombectomy or use medical management in patients with distal and medium vessel occlusions, directly addressing a common clinical dilemma with high-quality registry data. Here are the key takeaways from This Week in Neurology. First, the newly developed MAD-MT score helps clinicians risk stratify patients with distal and medium vessel occlusion stroke, showing that endovascular therapy benefits those with a score of 15 or higher, but may cause harm in those with lower scores. Second, post-stroke acute heart failure occurs in about 8% of large vessel occlusion patients undergoing endovascular treatment, peaking on day 1, and is significantly driven by moderate to severe cardioembolic stroke. Third, single positive lipoprotein receptor-related protein 4 antibody myasthenia gravis is a distinct clinical phenotype with a significantly higher disease burden and greater requirement for treatment escalation compared to other antibody subgroups. Fourth, continuous theta burst stimulation studies demonstrate that fasciculations in early amyotrophic lateral sclerosis are actively driven by descending cortical inputs, confirming a joint upper and lower motor neuron origin. Fifth, nerve transfer surgery for cervical spinal cord injury follows predictable electromyographic reinnervation timelines, typically ranging from roughly 7 to 10 months depending on the specific donor and recipient nerves. That's your roundup for This Week in Neurology. The full transcript and references are available on the episode page in your Audio Scholar library. This is an AI-curated summary. For clinical decisions, always consult primary sources and current guidelines. See you next week. If this weekly briefing is useful, follow the show in your podcast app so new episodes arrive automatically. And for audio briefings on your own clinical questions and papers, visit audioscholar.cc. This is an automated summary generated by artificial intelligence, which can make mistakes. Always review the original source materials.